Hey guys, in this video we are going to discuss roseola. Roseola is actually one of the 5 childhood exanthems that has actually shown a lot of staying power, and that's because the other childhood exanthems, many of them, there are vaccines for them. So varicella, measles, and rubella, there are all vaccines for. But roseola and parvovirus, we actually don't have a vaccine for. So these childhood exanthems still stay, and we actually see them a lot. They're very, very common. And thankfully, for the most part, unless you are a fetus, pregnant woman, or immunocompromised, they tend to be fairly benign. So let's talk about roseola. Roseola is actually caused by herpes viruses. So in most sources, it will list roseola as being caused by HHV6. There's actually 2 variants of HHV6, HHV6A and HHV6B, but it can also be caused by HHV7. Both of these are referred to as members of the Roseola virus family, which is a subfamily of the beta herpes virus family. So the beta herpes viridae includes cytomegalovirus, um, and they are all human herpes viruses. So just like all of the other ones, they are fairly large viruses. They're DNA viruses, and they replicate the same way as the other herpes viruses. They're a little bit confusing in this case because the target cell site and the latency site are not completely described. We know that the target cells and latency sites are lymphocytes, but we suspect that there are other cell types that HHV6 and 7 may affect as well. These guys are spread in the saliva, which is part of the reason we see them a lot in kids, right? Kids, babies, they love to put things in their mouths. When my son talks to me, half the time his fingers are in his mouth. I don't know why. I tell him not to. I see other parents tell their children not to. Kids just are constantly touching things and putting them in their mouths and then putting them back down for somebody else to explore, which is a great way to transmit illness. All right, so let's talk a little bit more about how this particular infection works. Typically, infections occur very early in life. It replicates within the salivary gland, and it's actually shed and transmitted in saliva. About 45% of the population is seropositive for HHV6 by the age of 2. So it's fairly ubiquitous among our little people, and almost 100% of people are seropositive for HHV6 by adulthood. So by the time they've reached their 20s, they will have expressed it or experienced it at some point. Serologically, these guys are associated with roseola. Roseola is also sometimes referred to as exanthem subidum. You'll typically hear me call it roseola. It's just a little bit easier to say. So as I mentioned before, HHV6 primarily infects lymphocytes, okay? Particularly, it seems to like to infect CD4 positive T cells, and it establishes a latent infection in T cells and monocytes, but it may replicate on activation of the cells. It's similar in replication pattern to CMV, and they're controlled well by cell-mediated immunity, and therefore are likely to reactivate in patients with AIDS or other immunosuppressive conditions. So let's talk about the actual clinical syndrome of roseola. So it's characterized by the very rapid onset of a high fever. And I really mean a high fever. So my son had roseola, and we were getting on an airplane. He was happy as can be, playing, etc. We weren't going far. We were only going to New York. It was a 2.5-hour flight. He passed out on the plane. I thought nothing of it. By the time we got off the plane, he had 103-degree fever. Over the next 2 days, he just stayed around that. I kept, cycling Tylenol and ibuprofen. I brought him to an urgent care. And, I never really got it below 99. Most of the time, we were up to 103. And, as a mom, I was very nervous. What's going on? He was only about 18 months. And then about 24 to 48 hours after his fever started, he broke out in this rash, this roseola rash. And I said, oh, thank God it's only roseola. And the reason I said it's only roseola is that roseola is normally very benign. Children recover, they do fine, and it was just a weird febrile illness that gave them this kind of lacy pink rash. The rash shows up on the trunk and the face. We were fortunate that it didn't happen, but with fevers this high, you do have to worry about febrile seizures, particularly in very small children. Now, look at these three rashes. This one is rubella, sometimes referred to as German measles. This one is measles, and this one is roseola. If you have an unvaccinated child, it's very difficult to tell these three rashes apart. They're very, very similar. So when you're thinking about how you're going to parse these clinical syndromes apart, you really need to think of a couple of things. You need to keep in mind the age of the child, the vaccination status of the child, what risk factors they have to have been exposed to either rubella or measles, and also kind of their clinical syndromes, right? Okay. So if they have rubeola, which is sometimes how um, measles is referred to. So you have rubella, rubeola, and roseola. If you have rubeola, remember we have our three C's, right? Cough, coryza, and conjunctivitis. Okay, so first off, you would look for those things. If the patient had those, as well as those Koplik spots on the buccal mucosa, then you would begin to see the rash as well. The rash is normally going to appear at the hairline and then spread over 3 days. So we're going to spread down, okay? If we're talking about rubella, the fevers tend to be a little bit lower. We tend to see sore throat instead. Now, with rubella, you can also see coryza. And you'll see those four-chimer spots on the soft palate. You'll have some lymphadenopathy, right, because the throat is sore. Again, the rash is going to begin on the face and then spread down, okay? Roseola, remember, we're going to see really high fevers just out of nowhere during the course of an airplane ride, maybe. As the fever subsides, then the rash develops. The rash normally starts on the neck and trunk and then spreads up to the face and out to the extremities if it's going to go to the extremities. It doesn't always go to the extremities. So those are kind of the ways you can tell those three apart. And I think as we have more and more outbreaks of some of these vaccine eligible illnesses, particularly measles, we've seen several outbreaks of that. It is important to be able to distinguish rubeola from roseola and rubella.